PET scan shows a large perirectal mass, widespread adenopathy, elevated LDH, plasmablastic lymphoma, the oral cavity type, which is ABC um, type, so activated B cell. So go to the next slide. So one of it, and show the results. So again, about 70%. Let's ask this question again, just while people are coming in to see what they would do. So let's re-ask this question. Okay, so would you send a patient like this for NGS testing? We'll see how people are, if they're influenced at all by each other. Oh, that's the exact same result. So, no.
Thank you.
So we are classic doctors, which means when we have opinion, it means it's right. Anyway, very good. So second, let's go to the next one. This is what you would do. How would you approach a patient like this? Those were the results. Let's ask the question again. Okay. So how would you approach this patient? R-CHOP, R-EPOCH, R-CHOP followed by radiation therapy to perirectal mass, R-CHOP followed by auto transplant, something else. So again, pretty close to it. Again, a little bit of a predominance of EPOCH. So with that, let's ask the panel how you would approach a patient. So Sven, do you want to?
So first of all, it's a strange name for the presentation, but there are lymphomas like diffuse large B-cell lymphoma of the skin leg type that can occur at the forehead. So that's just a pathological entity. But this type of lymphoma is a very aggressive lymphoma and CD20 negative. So therefore, of all the treatment options, the only treatment option that didn't include rituximab was other. So that's why I chose other.
So what
But because it's a very aggressive lymphoma, as a backbone chemotherapeutic, I would choose the EPOCH regimen. And then, of course, because there's nothing in addition to it like rituximab, you wonder what you can add to. And there are data out there for bortezomib and for lenalidomide, and this is a disease that pathologically is kind of closer to myeloma, and both agents are very active in myeloma, but we just learned from the PYRAMID study that bortezomib really has no activity in combination with chemotherapy in aggressive lymphomas, and also never had real activity as single agent in large cell lymphoma anyway. So in a setting where there are no randomized trial, no big data sets, where everything is really anecdotal, what I choose to do is EPOCH with 7 days overlapping with Revlimid, 25 milligrams for 7 days. And for all what it's worth and all my anecdotal experiences, all patients did well. That fine. Otherwise, from what you read when you read about it, is a very poor prognosis disease. On the research front, what kind of studies, if there would be, would you choose? What I would be interested in a disease that is aggressive and has EBV expression. There should be plenty of antigens that T cells could bite their teeth into. So a checkpoint inhibitor study, and maybe a checkpoint inhibitor plus Revlimid would be particularly interesting to me. And if there is CD19 expression, I would also think that a CAR T cell study might be of interest.
Excellent. So what about our EPOCH data now with ABC? Because obviously it's become kind of very popular to do. It's the number one choice that was picked here. There's obviously, but the recent randomized trial was just published. What's your thoughts on that?
First of all, yeah, I mean, we've waited a long time for these data to be presented, and just the fact that you had to wait that long was kind of disturbing information to begin with. But it is just what it is. It's a first look at the data without the full analysis. Clearly, and then if you look at the other randomized study that came back as a surprise, the PYRAMID study where the control CHOP arm did really well. So if you enroll patients in a trial that have a high likelihood to be cured with R-CHOP, then whatever you do in addition to it may not give you a big signal. So I don't know if all the patients that needed a more aggressive treatment were enrolled. I haven't seen yet, nor has anybody, the subgroup analysis of more aggressive subtypes. So all aware of the data that of course are retrospective, single institutions, and so on, that high proliferative aggressive lymphomas somehow seem to do better. when they're being treated with EPOC than CHOP. But again, all of that requires confirmation in a randomized study. So to this date, I haven't seen data that convinced me that for these very aggressive lymphomas, EPOC is not needed. So I kind of view it this way. For garden variety diffuse large B-cell lymphomas, I feel more comfortable giving R-CHOP chemotherapy. That's how I.
So John or Herbert, any other thoughts on that or the REPOC or?
Well, I was just going to say, and I would echo what Sven said, which is kind of how we got all brainwashed. But one thing, just to be cautious, I think, and it's really to highlight, is the data that is released so far in terms of the randomized study is not yet complete. We don't know data regarding efficacy of the regimen on cell of origin, and also there's a lot of it's publicized that it's a more toxic regimen than R-CHOP, but you have to remember the toxicity. The cytopenia toxicity is an intended effect. That's the purpose of the regimen, is to drive down all the way to low counts. So I would be cautious in terms of over-interpreting the equivalent
versus a long-term cardiac toxicity and things like that you won't see in the early data.
Exactly, with the CHOP type regimens.
Yeah. John?
Another attractive thing about EPOC is the infusional nature of the anthracycline is 96-hour infusion. So you have lower peak levels. It's really the peak level is what correlates with cardiac toxicity. So we're not shy at all in our group about giving EPOC to older patients because we know that it's going to have a much lower incidence of cardiac toxicity. So we need to see those long-term data as well.
Yeah.
It'll be interesting to see now in a randomized setting if that indeed holds up.
And so along those lines, if you have a patient that is 85 years old and you wonder if you want to give full dose CHOP chemotherapy, whenever you dose reduce R-CHOP, I think that does patients a disservice. And the nice thing about the EPOC regimen is that it doesn't have an age limit and the doses are being adjusted what will be right for a patient. But the oldest patient I've treated with EPOC is 98, he's doing fine. So that is another a point that in this more troubled patient populations, you reach the tolerable intended dose easier than you would do with a CHOP regimen.
And actually, just a little bit to me, it's not surprising. I mean, we did the ProMACE cytobomb versus MACOP-B versus MBACOP versus CHOP in the pre-rituximab era, and found you can rearrange the ejectors on the Titanic for DLBCL. It doesn't make a difference. I think that says it. But you do change toxicity profiles, long-term toxicity, things like that. So it's, again, it's not surprising to me, actually, that it came out about the same. It'd be interesting what subtypes show. But overall, there's nothing wrong with using it, especially if you're worried about older patients, cardiac toxicities, things like that.
So actually, that's a very interesting point that you bring up, because considering the equivalent efficacy of something like ProMACE cytobomb and BACOT kind of a regimen, actually I have a couple of times been able to rescue patients that had kinetic failure with a regimen like BACOT, where they, for example, they're getting every week something. And I know efficacy-wise it's equivalent to CHOP and so on, but at least you can use the the specific characteristic of the regimen to your advantage on occasion and be able to salvage patients.
Yeah, excellent.
But I mean, you make a good point that there's a long list of chemotherapy-only based regimens that have tried to do better than CHOP and have failed, and really when looking at clinical trials, trying to kind of do the next step, the backbone for novel agent combinations seems to be R-CHOP chemotherapy.
Yeah. A question here?
Could you all briefly talk about how you approach a patient with double hit or triple hit diffuse large B cells? I mean, is there a role for ibrutinib or BCL2 inhibitors in that setting, and how would you use it?
Well, if there's a role, then that role needs to be proven in a randomized clinical study. Initially, when people looked retrospectively why their patients were dying and identified all these double hits, it looked like that every double hit lymphoma is a death signal. But if you looked at it prospectively, there's a not insignificant percentage of patients that you can cure. So it is bad prognostic disease, but it's not as bad as it initially looked. And so for that reason, not having data on R-CHOP versus EPOCH in a randomized study, as a backbone, we would choose the EPOCH regimen. If there's a clinical trial, however, that, let's say, has R-CHOP plus going after one of the hits, let's say BCL2, my preference would be to enroll a patient into such a trial. And of course, targeting c-MYC would be of high interest too. And there are trials trying to look at PI3 kinase, MYC combinations. I mean, if you do a trial like that, that would be of interest in the context of the trial, of course.
Do you start them off with like R-EPOCH or hyper-CVAD? Like, what is your preference?
I mean, a classic double-hit lymphoma, I would start with dose-adjusted EPOCH. And then depending on the age of the patient, we would look at allogeneic donor availabilities just to know, to have that information. Sometimes you find these patients initially responding and then progressing right through your treatment. And then A, you have a problem to get them into remission, and B, if you get them into a transplant, that has to happen rather fast. But I think it's an open question, what do you do if you have a exquisitely well-responding patient that goes into a CR after 2 cycles and is a CR after 6 cycles of EPOCH? Where do you go from here? Do you do an auto transplant? Do you do an allo transplant? I think that's an open question.
So where do you go? They're 52 years old, they have double-hit lymphoma, they got a great response, they're in a CR after 2 cycles, you got 6 cycles in, what do you do? Have them talk to your transplant doctor?
I wreck my brain if I just leave it at that and observe that patient, or if I consider an auto transplant, rather than going through an allo route, because overall the auto versus allo data and large lymphoma are kind of equivalent, and I know that we may cure patients with upfront CHOP or EPOCH, and then to go straight to an allo transplant seems to be a high risk undertaking as well. So for me, the question then is, somebody who responds to EPOCH very well, do you leave it at that, or do you do an auto transplant?
And then do you want to go ahead and comment?
Dr. Mead?
Oh, I didn't have a comment. I actually had a question, but it'll be switching gears. So if you guys want to continue with this topic.
I think we switch. We go ahead. Go ahead.
Okay, so I have a question for Dr. Timmerman. So if you get a patient into a CR with a checkpoint inhibitor, what are your thoughts, and how do you counsel your patients on questions of proceeding to an allo versus just seeing what happens with the checkpoint inhibitor?
So for Hodgkin lymphoma?
Yes.
Yeah, so this question is starting to be addressed, and early on in the trials, some of the sites participating in these, both the nivolumab and pembrolizumab, took patients to allotransplant immediately, and they did what appears to be a little more graft versus host disease than you would expect. At the time, those patients would have had serum levels of the checkpoint inhibitor during their conditioning regimen, and it's thought that that is probably a bad thing. They did that because it was not known how long their responses would last, and it was thought that this was their only chance to go on to get an allotransplant. Now, I think the consensus is that most people would wait, which is what I'm doing, and then we would do the allotransplant at the time of relapse, because what's being found is that many of these patients will be drug sensitive enough at the time of relapse to go ahead and get their allotransplant. The patients who are able to stay on it for long term, they don't have cumulative toxicity. If you're going to have toxicity, autoimmune toxicity, usually you have that early on. So we're keeping patients on it and then sending them to allo after. And I have a couple of patients who were doing that too. And they seem to be responding, say, to bendamustine-based regimens and being able to go to allotransplant. The interesting thing is that the patients who have had a longer break from stopping the PD-1 antibody, then going to allo, have a lower incidence of GVH. And so it's probably good to give them a break, take them through the allo, and then what you can do is reintroduce the anti-PD-1 agent after the allotransplant. We know that allotransplants haven't been traditionally very good for Hodgkin lymphoma, probably because they have this immune escape mechanism. So people have done things like reintroduce the checkpoint inhibitor after the conditioning regimen's done, after the graft is on board. And there are numerous cases and some reports of people giving anti-PD-1 agents to patients who have failed and progressed after allotransplant, and seen that it's well tolerated, does not exacerbate GVHD, and people have achieved complete remissions. And I've done this in patients. And so I think that's the idea. We're going to continue to use allotransplant, but probably not in the very first remission you get, but wait for some sign that you're having failure of the agent. Go ahead.
Yeah, thanks. So I just have three quick questions. The first one is on CLL. If somebody that you pick up a Richter's transformation on, you were talking about clonality versus non-clonality. For those of us out in the community, how do you?
So you can, on paraffin-embedded tissue, you can actually send for B-cell gene rearrangement. Yeah. On paraffin-embedded tissue, you can send for B-cell gene rearrangement, which is Southern blot analysis, and it's available for most pathology laboratories, and they can tell you if you're CLL, the tissue would be your peripheral blood, circulating cells, for example, or the pathologist can actually take a look and take samples from a CLL lymph node, for example, and assess and see. But as I said, so this is not something that you can use for routine clinical practice. Why? Because the CLL itself can have clonal heterogeneity, and so, as Dr. DeVos mentioned earlier, so does the DLBCL. So negative BCL gene rearrangement is not a sign.
So they all get R-CHOP, basically. They all get R-CHOP.
At our institution, they typically all get our EPOC.
Mm-hmm.
Yeah.
So getting on the R-EPOC, recently there was a study looking at primary mediastinal lymphomas, and the R-EPOC did not look particularly good compared with standard R-CHOP. So is R-EPOC MAKE-OP B? I mean, are we back to needing a more randomized trials to define R-EPOC? And
I'm not aware of that particular study for primary mediastinal.
So with primary and large cell lymphoma, R-CHOP, when given, is often given with radiation. Yeah. And that's a disease that is predominantly a disease of young women. And so if you have a regimen that with EPOC that gives you a high response rate and cure rates and a high likelihood documented in trials that you can avoid radiation, I think that's really what you want to do. Along for that reason, I would opt with a regimen that doesn't require you to consider radiation.
And then I just have one more question. Whatever happened to HDAC inhibitors with diffuse large B-cell lymphomas? I have a patient who transformed from a marginal zone and he has now been in a complete remission and he's off therapy, by the way, now for 2 years. Is there any update on that? Seems to have fallen off.
I think there's so many other new agents that we haven't been able to find, agents that are really active. There's so many other options, but it is interesting that there's some new rationale for using HDAC inhibitors with immunotherapy and desensitized to other specific agents. So I think people are still thinking about it, but there's so many other new classes of agents that have sort of overtaken it for single agent activity.
I mean, it's all a matter of being able to, with the right biomarkers, slice out the right patient population for a particular approach. I mean, you will not have the all-comers HDAC inhibitor success story. And I think there are a few approaches in research ongoing to look into this, but I haven't seen dramatic results. Well, maybe that will change it.
I'd also like to comment on that a little bit, is that, as we get into the epigenetic approaches, I think we're really in the infancy. It's almost like with that current HDAC inhibitors, I'd almost say they're like IL-2 and immunotherapy. They're really very broad. They don't really target what we need to. With now new EZH2 inhibitors, what we're learning with the epigenetic approaches, I think we'll get better drugs that may do that by targeting the upregulations that are happening within it. That's a lot of work yet to happen, but I think it's just the original ones are like, interferon on IL-2. They can work in some patients, be dramatic, but it's so rare, it's hard to keep them going, but we will get better drugs. Actually, we have a question right here. Go ahead.
Yeah, just 2 questions following up on the double hit. Do you operationalize the double overexpressor but not true translocation double hits, so the ones with increased copy number are detected by IHC at whatever given threshold versus the actual translocations the same? And the second question related is, do you prophylax all of them if they overexpress or have a translocation of MYC? even if they don't have CNS prophylaxis, if they don't have the traditional risk factors, bone marrow involvement, high LDH, et cetera?
So the classical double hit lymphomas are GCB large cell lymphomas with the 1417 and the CMYC translocation. And there we would do. Okay, how about now? Okay, so much better. Okay, so the classical double hit lymphomas are GCB type lymphomas with a 1418 translocation and CMYC translocation. And those are what we think of when we talk about double hit having poor prognosis, where we do CNS prophylaxis. The double expressors, they are mainly, the big majority is actually ABC type lymphomas that just overexpress BCL2 and overexpress CMYC, but not based on translocations. And they have some intermediate outcome between your garden variety large cell lymphoma and a double hit. So those we not necessarily do CNS prophylaxis unless there are other reasons that normally would trigger to do that.
And then what prophylaxis, just intrathecal, or do you guys give methotrexate after the definitive treatment?
Yeah, so of course that's an open question that's not studied and compared, but the way we do it is the way it was published for EPOC, that you start on cycle 3 of EPOC with twice per cycle intrathecals during the cycle. So it's a total of 8 intrathecals you give during treatment. I'm aware of that others have given high-dose methotrexate at the end of it. I think both approaches are appropriate. There's no proof that one is superior over the other.
So my question, I don't know if this is working. My question is on anticoagulation and use of ibrutinib. Is that something that is okay to do, or something that?
The original concern came about on the original studies where a couple of patients on anticoagulation with warfarin had intracranial bleeding events, but that hasn't necessarily borne out as an absolute contraindication. We have certainly used alternate modes of anticoagulation aside from vitamin K inhibitors, so dabigatran and Xarelto type things, and there is indeed, although anecdotal, but established safety for concomitant use of ibrutinib with anticoagulation. And so, after the initial events, by the way, and the initial adverse events with bleeding, all of the subsequent studies later closed to enrollment for any patient that had any bleeding disorder or was on anticoagulation. However, the most recent study, for example, we did it with Waldenstrom's. That study actually did, in fact, allow patients to go on if they were on anticoagulation, and we haven't seen any safety issues. And then, as I alluded to last year, there was a retrospective review kind of a thing of cases published in Blood, again showing that it's not a contraindication, but it warrants close monitoring.
And I have one more question on Richter's transformation. The studies that you showed with checkpoint inhibitors, was that after anthracyclines, or is that brand?
Which one? I showed actually 2 anecdotes.
Right.
One of them was
the pembrolizumab.
yes, it was, yeah.
So that was after second line.
It was actually 5th or 6th line.
Okay.
It's very heavy. It was a very heavily treated patient, and I think I enumerated the prior history: fludarabine-based therapies, anthracyclines, radiotherapy. The patient had basically a lot of stuff. Yeah.
Okay. Thank you.
So let's do this. We got like 2 minutes, and I do want to go to the next question, because this is one I do want to hear from Sven. So this was a question. Let's actually ask it again. What is basically in this patient, if a clinical trial was available, you have access to a target, what target would you choose for this patient in this setting? So why don't we just ask the question one more time, and I do definitely want to hear Sven's opinion here. Now that we heard about all these opinions or all these targets, interesting. So John, I guess John won for something. He converted them over to PD-1. Anyway, Sven, what's your thoughts on a patient like this?
There you have your answer. So we're not talking about first-line treatment. Let's say there's a patient that relapsed, and now you wonder what to do. So that is a a disease that, and we have seen it, that expresses EBV. So if you have an EBV positive lymphoma, that is a very immunogenic tumor to begin with. So an immunological approach with checkpoint inhibitors, I think would be very interesting. And if you could combine those, which is not happening anyway, with Revlimid, even more so, I think that would be my first go-to trial.
That would be your trial.
Available. If there's CD19 expression, then as a plan B, CAR T-cell.
That would be excellent. Well, actually, I want to thank you all. That was excellent. And I do want to move on to the myeloma group. So.